I'm Kelsey Etheridge, and this is my image analysis presentation on the mandible. My objectives are review and understand anatomy, understanding basic facial lines and plans of the body, learn all projections used for the mandible, and distinguish between good and bad images. To the left, I included projections of the mandible series that we'll be using. We'll use the axial-lateral oblique, PA projection, AP axial, the Towns method, PA axial, modified waters, and the SMV. Here's an overview of the anatomy of the mandible. The mandible is the largest and densest bone of the face. It consists of a body, rami, and symphysis. The body is a horizontal portion, the rami is vertical with two portions, and the symphysis is the anterior and central part of the mandible. The alveolar portion is the superior border of the body of the mandible. The mental foramina is the superior and inferior border, which has small openings for transmission of nerves and blood vessels through the body of the mandible. The horizontal and two vertical portions meet to create an angle, also known as the gonion, as well as the ramus consists of two parts, which is the coronoid process and condylar process. Here we have the anatomy of the mandible. On this portion, we have the anterior, on the left side, we have the anterior aspect of the mandible. Here we have the angle, which is the gonion, the mental foramina, symphysis. We have the body, the mentis ponens. We have the ramus on both sides. To make up the condylar process, we have the condyle and the neck. On the right side right here, I have circled with the coronoid process. And we have the alveolar portion. As well, the same anatomy will be labeled for the lateral aspects. We have the symphysis, mental prominence. We have the mental foramina, the body, alveolar portion, the angle, which is the gonion. We have the ramus, the mandibular notch, the condyle, and the neck, which make up the condylar process. And we also have shown the coronoid process. Here is skull positioning lines. These are basic localization points and planes of the skull that will be used in the mandible projections. Some of the common anterior landmarks, which on the next slide we will have a labeling of this anatomy. These consist of the mid-sagittal plane, interpupillary line, acanthion, outer canthus, infraorbital margin, external acoustic meatus, lips meatal, inner canthus, nasion, mental point, glabella, angle of the mandible, which is the gonion. Also, common lateral landmarks that will be used is the glabella meatal line, orbital meatal line, infraorbital meatal line, acanthion meatal line, lip meatal line, and mental meatal line. Here we have the skull positioning lines labeled. As you can see, we have the mid-sagittal plane, the outer canthus, which is the outside of the eye. We have the infraorbital margin, which is kind of like the bags under your eye, and the angle of the mandible, which is your jaw. We have the mental point, which is your chin. We have the acanthion, which is located under your nose. We have the nasion, which is located between your eyes, like right in the middle. We also have the inner canthus, which is the inner, like kind of like your beside your nose. And then we have the interpupillary line, which is a line crossing the eyes. And we also have the glabella, which is between the eyebrows. For the lateral landmarks, we will always go from the EAM to find the lines of our face. So starting from the EAM, we can make the GML. We have the OML. We have the IOML. And then we have the AML. And then we also have the LML and MML. Along with the top attachment of the ear. Here's the angle of the mandible once again. And then we have the glabella ovular line. And we also have to distinguish between the 7 degree between the OML and the IOML, and the 8 degree between OML and GML. So here is the GML and which is 8 degrees from the OML. And then we have a 7-degree difference between the OML right here and the IOML. Here we will go over the atomic planes of the body just to give a review, because we will use these in our projections in the upcoming slides. So first we have the coronal plane, which is the blue one, separates the body anteriorly to posteriorly. We have the sagittal plane, which is red, separates the body from left to right. We have the transverse plane that separates the body inferior from superior. For our first projection, it will be the PA projection, demonstrating the mandibular rami. The patient's head and nose will be on the IR. You will center the IR at the level of the acanthion. For part position, the OML and MSP will both be perpendicular to the IR. For our central ray, it will be perpendicular to exit the acanthion, as well as holding your breath. For the structure shown in this projection, it will be the mandibular rami, and also showing the medial and lateral displacement fragments in fractures of the rami. For our evaluation criteria, we'll have proper collimation and marker placement, as well as showing good soft tissue and bony trabecular detail. We will have the entire mandible with no rotation or tilt. The mandible and rami will be symmetric on each side, with the MSP aligned with the long axis. Here we have images for our evaluation criteria. For our good image, we see that it is symmetric for the lateral borders and the entire mandible is shown. As for our bad image, it is tilted a little towards the right, as you can see, with a little superimposition of the cervical spine. And to correct this image, we will tilt the head back towards the left and lift the chin a little so it's out of the cervical spine. For our next projection, it is similar to the PA projection we just talked about. This one will demonstrate the mandibular body. The patient's nose and chin will be on the IR. You will center the IR at the level of the lips. For part position, the AML will be nearly perpendicular to the IR, with the mid-sagittal plane perpendicular. We will have the central ray perpendicular to the level of the lips, as well as holding your breath. For the structures shown, we will see the mandibular body. The evaluation criteria will be proper collimation and marker placement, as well as soft tissue and bony trabecular detail well shown. We will have the entire mandible with no rotation or tip. Again, we will look at the body and the rami to make sure they are symmetric for no rotation or tilt, as long as with the mid-sagittal plane with the long axis. Here we have images to go along with our instructions of how to put the patients. Here we will see the body, which is also known as the box jaw. In our good image, you can see the gonion angle very well, as well as the body. The entire mandible is shown, which there is titanium in this, but there will be artifacts in other images. This is the bad image, which the head is rotated and slightly tilted. You can see this by the lateral orbits of the orbits and the lateral. You can tell that there's a little more distance on the left side rather than the right side, as well as telling down here with the distance of these joints right here. To fix this image, you could rotate the head towards the left a little bit, as well as make sure our head is straight. One of the most common mistakes of repeats will be rotation and head tilt for these images. Next, we have the PA axial projection, which will demonstrate the mandibular rami. We will have the center of the IR at the level of the acanthion, as well as the part position. The OML and MSP will be perpendicular. Since it is an axial projection, we will have an angle. For the central ray, it will be directed 20 to 25 degrees cephalic, exiting the acanthion. For our structure shown, we will see the mandibular body, as well as demonstrating medial and lateral displacement fragments in fractures of the rami. For evaluation criteria, proper collimation and marker placement, soft tissue and bony trabecular detail, as well as the entire mandible with no rotation or tilt. The only thing different with the PA axial, we will see the condylar process. Here are the images to follow. In the first image, we can see the condyles and the rami, as well as the body in full, with good collimation. The mid-sagittal plane is going down the middle. It's pretty much not tilted or rotated. For our bad image, I feel like the angle is not enough. You can see kind of like the Peters ridges as are not filling the orbits as well as this picture of the good image. To correct this image, you will need to place more of an angle to get these condyles shown well. Next, we have the axiolateral projection, which will demonstrate the mandibular ramus. The ramus has a 0-degree head rotation. We will center the IR to the mandibular ramus. For the part position, the IPL will be perpendicular to the IR. The head will be in true lateral with the mouth closed. We will have a central ray directed 25 degrees cephalic through the ramus. The structure shown, the ramus will have to be parallel with the IR. As well as collimation, we will have to have proper collimation and marker placement with soft tissue and bony trabecular detail shown very well. For this, there will be no overlap of the ramus by the opposite side of the mandible, with no elongation or foreshortening of the ramus, as well as no superimposition of the cervical spine. Here are the images to follow. Remember, there is 0 degrees head rotation. The body will be in an anterior oblique rotation, so you can get it as close to the board as you can. For our good image, you can see the rami demonstrated really well, with no overlap of the opposite mandible, as well as no superimposition of the cervical spine. Here, the mandible is superimposing the cervical spine, and the rami is covered by the cervical spine, as well as the head is tilted a little more than needed. Next, we have the axiolateral oblique projections, demonstrating the mandibular body and symphysis. We will have to show the mandibular body, we will have a 30-degree head rotation toward the IR. For the symphysis, we will have a 40-degree head rotation toward the IR. And always remember the area of interest will be parallel to the IR. For the mandibular body, we would center the IR at the body of the mandible. For part position, you will have your patient in an anterior oblique position. The patient's head will be rotated 30 degrees toward the IR. For our central ray, it will be directed 25 degrees cephalic, passing through the body of the mandible. As for the symphysis, we will center the IR at the symphysis of the mandible. Part position, body is an anterior oblique, and the head will be rotated 45 degrees toward the IR. For the central ray, it will be directed 25 degrees cephalic, passing through the symphysis of the mandible. Here is the evaluation criteria for each projection. The mandible body. The structure shown with the mandible body will be parallel with the IR. We will have proper collimation and marker placement, also is soft tissue and bony trabecular detail. For this body, we will have no overlap of the ramus of the opposite side, no elongation or foreshortening of the body, and no superimposition of the cervical spine. For the evaluation criteria for the symphysis, it evaluates the symphysis of the mandible being parallel to the IR, as well as proper collimation and marker placement, as well as showing bony trabecular detail. We will have no overlap of the mentum region of the opposite mandible, no foreshortening of the mentum region. Here are images to follow the evaluation criteria. We will start here with the body. As you can see the body demonstrated very well with no superimposition of the cervical spine anywhere or no overlap of the opposite mandible. And the body is projected to be parallel to the IR. Here we have the symphysis, which is in the very front. This will be parallel to the board with no rotation or head tilt, and it is not superimposition of anything. As for the mandibular body with the bad image, We do have a little head tilt right here, which will not show the mandibular body on top of each other, as well as I feel like this image has more head rotation than needed. As for the mandibular symphysis, there's artifacts in the anatomy of which will be shown, and I feel like the head is not rotated enough toward the board to see the symphysis in the front. Next we have the submental vertical projection, also known as the SMV. Here we will see the entire bottom of the mandible. We will center the eye midway between angles. The part position, we will have the mid-sagittal plane vertical and the IOML as parallel as possible. We will also have a central ray perpendicular to the OML, centered midway between the angles of the mandible. The structure shown of the rami, you will see the coronoid process and condyloid process with evaluation criteria of proper collimation and showing great detail. To distinguish between no rotation or tilt, you will look at the distance between the lateral border of the skull and the mandible are equal on each side, as well as the condyles of the mandible to the pars are in profile. Now, the mandible cannot be foreshortened. The symphysis must extend almost to the anterior border of the face. Here are some images that will follow the evaluation criteria of the mandible. In our good image, we can see the condyles clearly. Right here, you can see right here. And the mid-sagittal plane is aligned to the long axis. Here we have the body, we have the rami, and the condyles, which is our main concern. As for the bad image, if we draw a line down the middle for the mid-sagittal plane, you can see that it is tilted, as well as looking at the lateral borders of the mandible and the skull to see that it has a little bit of more distance on one side. To correct this image, I would definitely tilt the head back to where the mid-sagittal plane is aligned to show correct positioning. Next we have the apiaxial projection, which is the Townes method, and it will show the mandible elongated. We will center the IR 1 inch superior to the glabella. For the part position, the OML is perpendicular to the IR, or you can have the IOML perpendicular to the IR, as well as the mid-sagittal plane perpendicular. For our central ray, we will angle the central ray. If the OML is perpendicular to the IR, we'll have 35 degrees caudal. If the IOML is perpendicular, we will have a 42 degrees caudal angle, each directed at 1 inch superior to the glabella. For the structure shown, we will have the mandibular condyles well demonstrated, as well as proper collimation and marker placement with very good details of the image. We will also need to see that there is no rotation or tilt by evaluating the mandibular body and lateral borders is symmetric, as well as the mid-sagittal plane being perpendicular or in line to the long axis of the grid. Here are images of the apiaxial Townes. For this good image, the body right here is well demonstrated, as well as the distance between the lateral borders and the mandible are symmetric. Here we have the bad image. I feel like there is too much angle. I would take a little bit of angle off, as well as closing the mouth, because the condyles are up here and they're obstructed by other anatomy in the facial bones. Here we have our last and final projection for the mandible, which will be the modified Waters method. We will center the IR at the level of the cantillon. For the part position, the chin will be placed upon the grid. You will hyperextend your neck so that the OML forms a 37-degree angle with the IR, and as well as the MML perpendicular to the IR. For our central ray, it will be perpendicular to exit the cantillon. For structure shown, we will see the body of the mandible and symphysis shown. For evaluation criteria, we will have proper collimation and marker placement, as well as very good detail. So we will have no rotation or tilt demonstrated by the rami. The rami and the bodies are symmetric, as well as the mid-sagittal plane aligned with the long axis. Here are images to follow the modified Waters method of the mandible. Here, for the good image, we are able to demonstrate the body with no superposition of the cervical spine, as well as the mid-sagittal plane being along the axis. And there is no tilt or rotation. For our bad image, you can tell that there is tilt and slightly a little bit of rotation because the lateral border of the skulls will have more distance on one side than the other. So the right side has more distance, which will mean that we need to rotate our head towards the left a little, as well as our mid-sagittal plane being a little off center. You can also evaluate the spine for this. To correct this image, I would definitely rotate the head a little bit and tilt it slightly to correct this image. Here we have our first question from the presentation. Number 1. Identify the anatomy that is highlighted. Here we have an axiolateral oblique 30-degree head rotation towards the board, which will show the body of the mandible. For our second question for the presentation will be, what two lines are perpendicular to the R for a PA projection demonstrating the mandibular rami, which will be the OML and MSP, which will demonstrate the rami. For our third and final question, which of the following is the correct central ray and angulation for an axiolateral oblique projection of the mandibular symphysis? The answer is A, directed 25 degrees cephalic through the symphysis. For all axiolateral and axiolateral oblique projections, we'll have a 25-degree cephalic angle through the area of interest, which is parallel to the IR. Here are my reference pages if y'all have any questions. And that is it.